Yeah? Okay, you guys, we're going to get started. Thank you all for being here. I'm Andrea Himoff. I'm the Executive Director of Action Utah, and I'm pleased to be joined today by Scott Langenecker, who is a board member of the American Foundation for Suicide Prevention, and he is also a researcher on treatments for depression and suicide prevention at the University of Utah. And we have Carrie Butler, who is the Policy Director at Action Utah, here to talk about suicide prevention today. I want to talk about suicide prevention from a couple of perspectives today. One is community initiatives, and the other is policy initiatives. But maybe we could start with just a really, really basic snapshot on suicide in Utah. Scott, can you provide something like that for us today? Okay.
I can. So this year was the first year in over a decade that we had suicides in the state of Utah plateau. Numerically lower, but basically stable from last year, which I'm hoping is a sign that we can move things in the other direction and start reducing the rate of suicide in the state. One of the things that we're doing in our initiative is to try and figure out why the numbers have stabilized and if we could do more of what might have been leading to that stabilization.
Great. Okay. Do you have anything to add to that, Carrie?
No, we're just thrilled you're here. And also, that is really interesting news, and I need to clarify that I am not an expert in any way, shape, or form on suicide prevention, just the policies that we're working toward in conjunction with organizations such as yours. So we hear that news, and I think it's really fantastic and really important to also remember that this is not the time to be like, yay, whatever we did. And so I appreciate that you're trying to identify exactly what is working and what
we need more of that.
Yeah.
Whatever it is.
Right.
Well, and we're all coming at this issue partly because we've had such high suicide rates, and we know it's a preventable issue, right? And so we've been the fifth and now I believe the sixth highest suicide rate in the nation. But there's multiple ways that we can tackle this issue, and there's so many things that are being done. So I kind of want to focus on that today. Maybe start with community initiatives. What are you aware of or working on through the American Foundation for Suicide Prevention and your work at the U in terms of how community participates in prevention?
I think the biggest change that I've seen in the 20 years that I've been doing this is the openness that people have in talking about brain illnesses, which includes, we call it mental health, but they're brain illnesses, and how people actually pursue self-care, both on a family level, a community level, and a professional level. And I think that has opened up avenues for support at the community level that were heretofore, I think, closed off. Mm-hmm. People didn't feel like they could approach others in the community and seek out support and help. Mm-hmm. And the data suggests that that social support is actually the glue that potentially is the best protector, apart from immediate self-care plans. The social support is a critical component of reducing the number of suicide losses.
Mm-hmm. Can I ask a follow-up? Am I allowed to do that?
Sure.
Okay. Follow-up question. Mm-hmm. In your experience, have we started to move toward a society where people are comfortable saying, I need help, reaching out to the community? Because I know that when we were first talking about this as public health professionals or what have you, it was we need to destigmatize mental illness. We need to destigmatize what did you call it? Brain
illnesses.
Brain illnesses. I love that. Have you noticed that that we've been starting to accept that more as
I think people are more comfortable with the vocabulary now.
Yeah.
And I think that we are stamping into the dust this idea that there might be characterological or personal weaknesses that are causing these things.
Got it.
And it's really something that is treatable for most people.
Well, good work.
It's not mine. I'm just following in the coattails of others.
Somebody's doing it. Okay.
So what are some of these community initiatives? We know there's QPR training, for instance, for training community members on how to be responsive. Can you speak to that?
AFSP actually has several different programs that we promote. So QPR is a program that we do not specifically promote, but we do something very similar, and we find that QPR is actually very similar to what we do, which is called Talk Saves Lives. We also have initiatives both at the educational level and at the professional level for More Than Sad, which is our way of sort of destigmatizing actually suicide crises that people might be going through. And then there are some college-specific initiatives that we have as well. But we're just one of many organizations. We're the leading research supportive organization for suicide in the country, but there are some other ones as well.
In the healthcare field, there are some community initiatives like CALM. So,
I'm not familiar with that one, yeah.
Which is one where the care providers are speaking with patients about firearms, for instance. Are there firearms in the home? If there's some sort of depression or a mental health issue or a brain illness, as you refer to it, that there is a conversation that happens around the firearms and how to handle firearms when there is a combination of firearms and mental health issues in a home.
Yeah.
So that there's more of a conversation about some correlations and how to stay safe, right? And firearm safety is another piece of suicide prevention, and there are community initiatives around that. So why don't we, Kara, you can speak to one of the ones that was announced recently as a public-private partnership with the state and coalition of organizations.
Right. So there is going to be a public safety campaign around suicide prevention. It was a private-public partnership with organizations like Intermountain, the LDS Church. I think the state put in some money. The Utah Sports Shooting Council also participated in funding this, and it will be an effort in a series of commercials or ads, or what do you call those things? They play on TV.
Public
and you watch
service.
them.
Yeah.
PSAs on firearm safety and locking up your firearms. And it's not specifically going to be around firearms, but we do know that in the state of Utah, we have quite a bit of easy and open access to most lethal means. That's one of the things that we need to be talking about, especially in our gun-owning communities, is how to stay safe, particularly when a person is entering into a crisis. And I think this is going to be a really interesting project. It's supposed to be similar to the Parents Empowered, and we have a lot of data to indicate that the Parents Empowered campaign reduced the use of alcohol use in minors by a significant amount. So we're excited to see how this actually plays out.
And in conjunction with the Zero Suicide campaign that's happened throughout the healthcare industry, and hopefully will be even broadening from where it is, some really good community impact through all these various programs, right? What about, go ahead.
Can I just elaborate on that? So one of the things that I've learned in the long time that I've been working with AFSP is that the language we use about firearm safety is actually really important. So many people who own firearms own them for family safety.
Yes.
And explaining to them that at the moment that there is somebody who is in a suicide crisis, the most dangerous thing to their family is actually the firearm in the home at that moment. It's not home invaders, it's not the government, it's actually people in their own family who are a danger to themselves. And then also explaining that the crisis may be acute. It may be something that lasts 10, 20, 30 minutes at a given point in time, and having that means to prevent them from having access to that firearm in those 10 to 30 minutes is actually a critical component of safety. People don't often understand that suicide crises sort of wax and wane, and it's when the person's at their peak suicide crisis that we need to have means reduced. So the most important message that I try and send to people is it's not about the government trying to control your access to firearms. It's about you taking care of the safety of your family.
Right. And what does that look like?
What does that look like? So what we recommend and what AFSP has actually done is we've advocated for gun locks. I think we've actually given away thousands of gun locks here in the state. Also having a safe. I advocate for having two safes, one for the firearms and one for the ammunition. That way there's a fail-safe in case something comes to pass where the person who's in crisis has access to one but not the other.
Great. So safe storage really is what it comes down to in terms of our own individual part in firearm safety.
Yes.
When it comes to policy, what are some of the top policy priorities of the American Foundation for Suicide Prevention to prevent suicides?
So our 20% reduction by 2025 campaign has 4 basic pillars to it. So the one is firearm safety. Another one is actually working in the correction system. So people who are in corrections or who are coming through or in or out of corrections are at a much higher rate of suicide crisis and loss than the population.
I just read that this morning. I didn't know that.
Yeah, it's one of those hidden epidemics. And then also in the medical professions. So first responders, police officers, firefighters, and doctors are at increased risk for suicide. And actually having simple programs where we actually screen for suicide in ERs would be one way to sort of identify people who might be at risk and to then develop crisis prevention plans to keep those folks safe. And I always forget the 4th one, so I'm going to pass on that.
Okay, so let's talk about some of the policy we know is coming up for 2020. Who would like to start? Do you know about any bills coming up for 2020 that you want to share or that you are able to share at this point?
I don't.
Okay.
Well, I know some things, but not anything specific yet.
That's okay. All right, so let's turn to Carrie because I know she knows a couple.
Okay, great. I actually just heard one this morning in Health and Human Services, and I think a couple of you were in listening to Health and Human Services this morning. Okay, so did you hear Steve Ellison present about the mobile crisis teams? There we go. Mobile crisis teams, which I think will be really helpful right now, and you'll be able to hopefully correct me because I'm going to butcher this, but we know that we do not have beds for acute crisis. We know that we don't have beds for, what is it when it's not quite acute?
That's the day outpatient treatment.
Yeah, but there's like a word for it that they were using. Thea, do you remember what he was calling it?
Describing a service for those people as the warm line?
Warm lines, yes. So there's like acute crisis, and that is that 10 to 30 minute period, right? And then there's also people who may not quite be at that point, but are entering into acute crisis, and we don't have beds for them. And not only that, the only real access point that people have to services at that point is to enter into an emergency room, which is often not the best place for a brain illness, because they also don't have psychiatrists, psychologists on staff in the emergency rooms. So it is the place that we can get the quickest care. It is not the place that we can get the best care. So mobile crisis teams are a mechanism to kind of address that issue, which I thought was really, really fascinating. And actually, law enforcement were there to testify in favor of this bill, specifically for people who are having behavioral health issues and not quite interacting with the criminal justice system yet. We can send out a mobile crisis team and get them into services that can prevent them from entering into the criminal system. And I think that sounds really interesting and really exciting for the state. We know that this is happening in a few other states with really great outcomes, and so I'm thrilled to hear Representative Ellison talking about it.
And that bill is crisis services amendments.
I have no idea.
It is.
Okay. I just heard about it today.
Does that one include the funding for the existing mobile crisis teams or expanding?
It should be expanded.
It seems expanding and creating a behavioral health receiving center pilot program.
Because those folks who are, it's hard to ignore this happening in Utah, but the Huntsman Mental Health Institute, one of the goals of that is actually to move to providing more services in rural areas.
Yeah.
And so having mobile crisis teams that actually serve more rural areas will be a critical growth area for us, hopefully, in the future.
Ooh. Yeah, that was such an awesome announcement.
It was really exciting.
What else?
We know that there are some bills coming up around mental health parity. Mental health parity is something that passed federally in 2008, and it is just basically saying if you're going to care for the physical body, you also have to care for the The brain illnesses?
The control center.
The control center. Man, I love that term. The brain illnesses. Well, the control center. So, and we see what is happening in order to skirt around the cost that might occur to insurers. People are providing inadequate network coverage. I know that we do have a provider shortage in the state, but we also have a really difficult time paying the providers that we have because they have a hard time networking with some of the health plans. So we're trying to smooth that out a little bit by making a few mandates in the state to require adequate coverage or adequate mental health providers in the plans. Anybody who's ever tried to get into see a therapist or get their kiddo to see a therapist is familiar with getting the list from their provider and calling every single number on that list and spending days and days trying to get in with somebody. We're trying to shore that up so that people who are on those lists are actually available, are actually taking new patients, and are actually able to accept the coverage that you have.
Yeah.
So that'll be really exciting, and I think really, really helpful, particularly for people who are not in acute situations but would like to stay out of acute situations.
One of the surprising and little known set of facts about this is that the behavioral health, we call it the behavioral health carve out for insurance plans, is typically only 5 to 10% of an insurance plan spend out. But we also know from a numerous number of studies that if you don't take care of the brain, behavioral, mental health component, people come into other medical professionals for co-associated conditions like pain, for illnesses, and that if you actually provide integrated care, there's several VA studies that have suggested if you provide integrated care, you can reduce overall costs and increase wellness and functioning. So this is one of the things where those of us who've been studying this for a long time sort of continue to scratch our head when we're not banging our head as to why the system is set up in such a way that we're actually spending more money to provide substandard care.
Right.
Because that's exactly how our healthcare system is set up now, to spend more money to provide substandard care for many of our people.
We're providing Band-Aids for things that we could intervene so much further upstream and prevent. I do appreciate, though, that we are starting to hear people talking about this more and more, the integrated care and the wraparound service and treating the whole person, and I think that's the direction we're going to head, but I think we're 20 years out.
Speaking of the wraparound service, Representative Elison also spoke about another bill today. I don't know if you heard this one, Carrie, the Mental Health Treatment Access Amendments. It was his second bill he presented. And it's a bill with a large fiscal note that the committee unanimously passed as a committee bill today. But it is allowing a council that's already in place, the Forensic Mental Health Coordinating Council, to study and provide recommendations on adult hospital beds within the Utah State Hospital and the needs for that, showing that our hospital bed numbers have not risen with our population and are at the same place that they were in 1980. And a piece of this bill that I thought was really interesting that he didn't mention specifically, but it's in the draft, is that it provides for the Department of Human Services to manage a housing assistance program for people who are coming out of the Utah State Hospital.
Oh, great.
So again, thinking more comprehensively about what do these individuals need to keep them in a healthy place or put them in a healthier place more comprehensively.
Ooh, I love that.
Yes. Do you know about Daw's bill that Representative Daw announced a bill today as well? And since we're on this thread of mental health bills, I thought this was an interesting one as well. It's a bill, did I write down the name? I did. Substance Use and Healthcare Amendments. And this, you know this one.
Tell me about it, because he mentioned it, but I can't remember.
This bill is having the state apply for a Medicaid waiver through CMS to provide Medicaid to inmates 30 days prior to release.
Yes.
If they have a behavioral health or a mental health issue, so that once they depart from a jail, they have the ability to have treatment ongoing.
So it's like a warm handoff from there. Yeah, I think it's a great plan. I'm excited about it.
Yeah. So that's kind of the mental health side.
Mhm.
Are there any others on the mental health side?
I'm sure that we're going to see quite a few others because this is such an important issue that has risen to the top of public interest, particularly with the Kempsey Gardner report on the state of our mental health availability as far as clinicians go. Just a few months ago, I'm sure you're aware of that. So, this is probably just a few of what exists and that we haven't explored yet. That's why it's always fun to enter the legislative session to see what the heck is happening.
For sure.
And I wanted to
yeah.
sort of add a thanks for a bill that was passed last year to provide support for residency training for psychiatrists here in the state. So the legislature provided support for 4 new psychiatry residents in 3 successive years. So that's 12 in the next 3 years. The Idaho legislature also provided support for 2 psychiatry residents, and I don't know if that's a cumulative over 3 years or not. The reason why this is so important, the reason why we like to push additional bills like that, is because of these pipeline issues for service providers.
Yeah.
And that's not just at the level of psychiatrists. We need that for psychologists and for social workers and for psychiatric nurses as well. So I'd like to encourage those who are advocating for legislative activity to sort of promote that too. This was awesome. It was welcome, and we need more of it.
We need a lot more, right?
Yeah.
What is there as a gap? Do you know exactly what it is between the mental health care providers in the state and the population? We're one of the lowest, I think, per capita in the nation.
I don't want to put that number out there, but it's 51st.
50.
So we are 51st. We're behind all states and the District of Columbia in care provision capability.
And we know that there are some rural counties that have 0 mental health professionals in the entire county, where people are having to travel quite a distance in order to see somebody. So I do know that Representative Elison again has worked on some telehealth capabilities with insurance providers to be able to cover that, which I think is obviously a warm person that you can actually go and meet with is best. But if you're in a rural area that doesn't have any other options, I think it's a really great way to address that issue.
Yeah. Okay, well that's sort of the mental health realm of suicide prevention. There's other policy initiatives to tackle this problem, or to tackle pieces of the problem, because there's no silver bullet. I hate that term, especially around suicide prevention. So there's no one answer, right? It's multiple answers, and we need all of them together to really make a dent, right? What are some of those other policy proposals?
So obviously our favorite thing to talk about is the ERPO bill, Extremist Protective Order, which allows for a law enforcement or family member to file for a protective order to temporarily separate somebody who is in crisis from their firearm. We expect to see a couple of those in various forms come through the legislature, either in the Senate or the House. And we know that there's plenty of support for those across party lines and across the state. So we're hoping to see that at least have a discussion, or at least have a real meaningful discussion about what it looks like in situations where our PSAs are failing and our family members are not able to adequately store firearms from somebody who's in crisis, or in the situation where all of our gold standard mechanisms to remove a firearm from somebody who's in danger have failed. We think that this is a great way it's a last ditch effort to protect somebody and wrap them up in services and keep them safe. So we're excited to see that on the agenda again.
And to elaborate on that again, the goal of ERPO is to buy time, right? So we're buying time to keep the person safe so that we can provide treatment and get them better. It's not a permanent revocation of rights.
Right. Yeah, that's the beauty of it now. I think it's been really kind of spun a little bit for gun Second Amendment rights advocates. That this is a gun grab now. We anticipate that this is going to, because there are so many other really amazing community programs And there are people who are doing such amazing work, educating people, handing out gun locks. Ellison passed a bill to provide coupons for reduced cost for biometric safes, for example. We know that that's an amazing effort, and we know that it's going to work. We expect that the CRPO bill would impact fewer than 150 people a year in the state. It's a very small portion of people, and we know that in states that have it, that have adequate support for it, that they've seen a reduction of 10% in their suicides, particularly their firearm suicides. We know that it works. We know that it's going to be rare. We know that it's going to impact the most extreme cases, and yeah.
And a majority of law enforcement folks who are in the field addressing these issues support ERPOs.
Yeah.
Who else supports ERPOs?
NAMI. Hi. So we've been working really closely with Sharon Aiken at American Foundation for Suicide Prevention. They're very supportive of this bill. The Domestic Violence Coalition is very supportive of this bill. Anybody who's working in recovery services in that way is quite supportive. The Law Enforcement Legislative Coalition was supportive last legislative session. Now that remains to be seen. Now we still don't have language yet, so they can't weigh in specifically. We know that businesses are getting involved in this. We know that we started seeing kind of a tide change in political opinion on this, maybe in June or July when we had those back-to-back mass shootings in El Paso, Dayton, and Gilroy. People suddenly were like, what should we do? What can we do? What are the things that we do? And we know that red flag or ERPO bills were initially created to prevent mass shootings. So the suicide prevention is a happy what's the word? Oh my gosh, I can't remember the words. You know, it's a happy little thing that happens accidentally after you pass a bill. You weren't meaning for it to happen, and then it happened. Yeah, sort of. Okay. Well,
Silver lining.
Silver lining. It's a happy accident.
Yeah.
That's not what I meant to say. I'll think of it. And then I'm going to shout it out in like the middle of a meeting, and you guys are going to be like, oh,
Who else has been involved in developing that policy here in Utah?
Right. So that actually has been developed really intentionally and really, really carefully with all of those supporters that I mentioned, and has had buy-in from all of the people who are regularly boots on the ground, seeing people who need these types of interventions.
Including courts and
Right.
Even gun owners, right?
Mm-hmm.
The State Suicide Coalition.
Uh-huh.
How do Utahns feel about that policy?
68% support.
And who are those 68%?
Those people are 60% of those 68 are gun owners in the state of Utah. So it's not just, I think because it is such a hot button issue, and because it's been spun again, people are perceiving this as a gun grab. People understand are hesitant to support what they don't understand, but as soon as they understand that it's so limited and it's so narrow and it's so targeted and it's been weighed in by all of the experts in the field, they're like, yeah, I support that. We want to find a way to protect these people as well. We want to find a way to keep these people safe as well, right?
Does it infringe on Second Amendment rights? Or does it abide by Second Amendment rights?
Yeah, it does. I mean, yes.
So, that's a big question that comes up. Is it
Right.
constitutional?
Right. Well, here's what we're looking at, right? We're looking at people making really reactionary policies based on fears. And I think that's why the ERPO is so important, because it's been developed in the way that most protect Second Amendment, right? So if you commit a crime with your firearm, whether that's self-harm or harm to others, you're prohibited permanently from ever owning a firearm again. See this as a way to intervene a little bit further upstream, like we were talking about in some of these community programs, in order to prevent somebody from losing their Second Amendment rights permanently.
Right, because this one is temporary, right?
Yeah. And it's not a criminal injunction, it's a civil.
I think it frames the question incorrectly to talk about whether it infringes or doesn't infringe on Second Amendment rights. Because the Second Amendment was actually developed specifically to protect the individuals in the country from government oppression.
Right.
And in this case, we're talking about protecting individuals from themselves or protecting other individuals from those folks.
Yeah.
So it's a different question.
And it turns out that the
That's an
court
interesting
system agrees
perspective.
with you, right? The court system has found it to be consistent with the Second, the Fourth, and the 14th Amendment.
Mhm.
So in other words, not unconstitutional, quite clearly determined by the court system itself.
Right.
And I think there just has to be some clarity in messaging, because there are different levels of Second Amendment restrictions,
Right.
and this is really acute, emergency, temporary.
Mm-hmm.
Acute, emergency, temporary.
Right,
And not criminal.
right.
Which I think is the best part about this, is because these people who this would apply to are not people who have entered the criminal justice system, and they are not people who have entered the behavioral mental health system yet, right? And if we can get them into one and not the other, and get them services and restore them to wholeness, that's the ultimate goal.
And I think every firearm owner, whether they do it for sport or for protection, whatever it might be, when they purchase a firearm, in the national, I always get this messed up, the National Shooters Foundation, which is the foundation that supports the distributors of firearms, has actually partnered with us to provide more information about gun safety
Right.
at the point of sale. And any person who purchases a firearm should be having this thought in their mind, that if I am mentally unwell, then I probably shouldn't have a firearm
Right.
during that period of unwellness.
Right.
That's just a rational thought,
Mm-hmm.
which is separate from the Second Amendment.
Right.
And if I become well again, then I should be able to get my firearm returned to me then.
Yes.
Right.
Yeah. I love that you're doing that work. I think that it is such an important dialogue to be having with the people who are actually owning the firearms, right?
Mhm.
The other sort of myth out there is that if individuals don't have access to firearms, they might find other means
Right.
for suicide losses. And the data suggests, because the crisis often is very acute,
Mhm.
that that's not true,
Right.
which is why the 10% reduction is actually the case.
Mhm.
So giving people time, we're literally trying to buy people time so that the suicide crisis will pass and they can
Mhm.
get better care.
Right. So here's a question I have for you that I hear all the time and I don't know how to answer. If a person is in acute crisis and we only need a 30-minute window or a very temporary period of time to separate them, then how do we know that they're in crisis in time to remove the firearm?
That is exactly the reason why we have the ERPOs.
Great.
And also there's an acknowledgement within that, is that the ERPO is not going to be perfect for exactly that reason.
Right.
Is that people will move in and out of crisis at moments that are often not even known to them, let alone in ways that they can share with other people.
Yeah.
So we're attacking part of the problem here.
Yep. Great.
Is there a mental health or behavioral health component to this bill that expands it beyond the scope of simply creating that time and space and distance between a person and the most lethal means?
Yeah, that's actually a really good question. So inside this, I don't know, I can't speak to the other states' bills. Monica probably could. 100% could, not take out probably. But in our particular bill, this allows a judge to order an examination of the respondent by a designated examiner. And that's a really important piece of the legislation, because at that point, the designated examiner can make recommendations for specific treatment and not just, something that is mandated by the court. You need to have anger management classes or rehab or whatever it is. It's very specific and very tailored to the person. Now, in a perfect world, we would couple ERPO with funding to be able to provide that wraparound care, and that's ultimately what I would love to see us working towards. And I think that with the mobile crisis teams and with all of these other integrated care services that we're starting to see be talked about and be hoped for and be planned for in our state, I hope that that is the ultimate outcome.
In terms of outcomes, though, what does the data show us about the ERPO laws in other states that do recommend behavioral health services? Does that have an impact?
Right, so Monica has taught us that in states that have had this the longest, we know that 30 to 40%?
Yeah, it hovers around.
Yeah.
From 29 to about.
Right, and remember the ERPO is only impacting people who have not intersected yet with criminal justice or behavioral health services. So these are people who are in crisis, who have not, for whatever reason, sought any services. So it's really compelling to know that in other states, 30 to 40% of people who are respondents or subject to an ERPO are actually getting the services they need. So it is indicating that not only are we keeping these people alive during their period of extreme crisis, we're helping them into services that provide better outcome, better life, better quality, better expectation, etc. And then restoring them to full gun ownership if that's what they choose.
What about the concern about using this bill or this law as retribution? The angry wife scenario where I could call law enforcement and have them, or call a court system and ask a judge to order the removal of my husband's firearms because I'm angry at him. Is that possible under this bill?
I mean, yeah, I guess you could if you're really, really, really very sneaky, but the bill has a pretty stiff penalty for people who are falsely accusing somebody. So it carries a third-degree felony charge with it, the same as our other protective orders in the state for domestic violence or civil protective orders. So there is a cooling or a chilling aspect of the legislation to make sure people think twice before they're...
Is there a history of false claims for this?
No, I mean, I suppose there could be that just aren't reported, but in all the states that have ever had one, there has never been a false accusation made that made it all the way through to a person losing access to their firearms.
Mm-hmm. That's sort of the scope of the policy that we're looking at so far, though there's sure to be more policies that do pop up. Should we do a quick recap of what's happening with conversion therapy as one of the big suicide prevention bills of last year?
That was one of your top priorities last year.
It was, and you know, at the risk of being overly concrete in this, I'm going to be overly concrete. Providing a therapy that is proven to not work to people without their consent, in my view, is abuse. So I'm just going to put it up like that. And putting that into law, whether we put it in law or don't put it into law, in my opinion, and I've worked with tons, not the right word, hundreds of individuals who have
loads of them,
who have experienced
just people coming out the
stigma
walls.
And discrimination for how they were biologically designed by our Creator.
Right.
And so having somebody say that that's wrong or that they're broken is to me a horrible thing to think.
Right. I'm really interested to see how this legislative session plays out, because I know that there's going to be some attempts to resurrect or make carve-outs for people who still choose to put their kiddos in conversion therapy, and I think that the data shows in the state that a majority of Utahns do not support, and they feel the same way that you do, right? That this is not this is criminal behavior, right? So
I mean, and if you want to do that to your kids, maybe that's your legal right, but we as a state should not condone it.
No.
It shouldn't be legal.
Right, I'm with you. So yeah, let's go team and keep our eyes peeled for those things.
Yeah. Okay, so those are the questions I had for you. I want to open it up for questions from anybody else in the room, and then after that I'm happy to offer a tour of the state capitol for anybody who's interested in, as we do every month during interim session. So let's start though with questions. Are there any other questions from the room for these individuals? Yes.
You said suicide rates have plateaued. In your personal experience, are there very specific measures that you would link that to?
Well, I'd like to give a shout out to another state-sponsored initiative, which is Safe UT. So in the state of Utah, we have the number one cause of death for individuals 10 to 19 is suicide still. And we'd like to make that a much lower number, hopefully 3 or 4 or 5. The mobile crisis teams, I think, are actually really a very effective means for reducing acute suicide risk. But the thing that's very neat about Safe UT is it is in both providing crisis services to middle schoolers, high schoolers, and now many university students. But it also sends a very powerful message. And the very powerful message is that here in the state of Utah, all the key stakeholders are committed to providing crisis prevention services for people who are in need. To me, that's actually a more powerful message than the actual service that we're providing. But I'm glad to have both.
Yeah. Yeah. I'm glad you brought up Safe UT. Okay, any other questions? So before we leave off with our live stream, if somebody is feeling suicidal or questioning suicide, what can they do, Scott?
Well, we have a national call number, which I should have memorized, but hopefully it'll become a 3-digit number very soon, and that way it'll be easy to remember. There's a national text line, which I do remember, which is 741-741. We do have Safe UT here in the state that you can access, and even though I'm not supposed to say this, you're not technically in the state, maybe on the borders of the state, you can still use Safe UT, and that would be cool.
Did you hear that, Wyoming?
Great. Well, I want to thank you both so much for this conversation and for helping the community understand what's being done around suicide prevention in the state. Thank you very much.
Thanks, Andrea.
Is there anybody in the room who is interested in a tour of the state capitol who has not done it before? Okay.